الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. يسعدنا ويشرفنا إن احنا نكونتينيو our Benha online orthopedic course review course. وطبعا الكورس المميز جدا بتاع الهيب، وهيكتمل النهارده بوجود two eminent speakers. اولا نشكر استاذنا استاذ دكتور مدحت بيه رفعت على انه شرفنا النهارده بمحاضره شيقه جدا على ال MRI of the hip. أستاذ دكتور مدحت بيه رفعت is a professor of diagnostic surgery and head of diagnostic surgery diagnostic radiology department, Benha Faculty of Medicine, and vice dean for the postgraduate affairs. He will be with us for MRI of the hip joint. والمحاضرة الثانية هتبقى مع أستاذ دكتور أحمد خميس, Assistant Professor of Orthopedic Surgery, Benha University. He will speak about the rationale of hip replacement, of total hip replacement. هنبدأ أول محاضرة مع أستاذ دكتور مدحت بيه رفعت. May you start, sir?
بسم الله الرحمن الرحيم. حضرتك كده الصوت واضح كويس؟
واضح يا فندم إن شاء الله.
واضح يا فندم.
تمام. بسم الله الرحمن الرحيم. طبعا يعني بشكر جدا يعني جمعية جراحة العظام، وعلى رأسها يعني رؤوس كبيرة قوي وإيميننت فيجرز عندنا، الدكتور عادل العدوي، الدكتور محمد أسامة حجازي، الدكتور جمال حسني هو رئيس الجمعية دلوقتي، وطبعا الارينجمنت مع أستاذنا الدكتور جمال الأشهب بمجهوده الكبير، وباقي ستاف الأورثوبيديك سيرجري كان ليهم باع كبير جدا في رفع قدر كلية طب منها. الحقيقة الدكتور أشهب كان طلب مني إن أنا أعمل أي حاجة بالنسبة للإم ار اي هيب، وانا هحاول النهارده ان احنا واي ام ار اي، واي نوت اكس راي، واي نوت سي تي، واي نوت ultrasound. We will start for that. First, I think I have all of these staff members starting from our university president Professor Gamal Saeed and our dean Professor Dr. Mustafa Al-Ardi and all the attendance for us, and also the whole professors of Dr. Gamal Husni, Dr. Adil Adawi, Dr. Osama Hijazi, and our colleagues now in this session. I have the pleasure to have this opportunity to talk about the YMRI. We will start for this piece of test tube. This is very nice demonstration for what we can see from the plain X-ray. All of this test tube can explain for us about the differential density for the plain X-ray. This is the air density, this is the fat, and this is the water, and this is the bone and water. From that point of view, we can imagine what we are looking for the plain X-ray. The same like that with the MRI, but it's now in different situations. For us, I think all of us know about this photo. This is a plain X-ray also for the hip joint, or what was called the hemipelvis anatomy. We have two parts, right side and left side. So this is the right side. The hemipelvis anatomy coincides with the three components about the ilium, the pubis, and the ischium. All of them are fused in a circle, which is called the acetabulum, and then can covering the femoral head. This is too easy to manipulate, just a plain X-ray for the hemipelvis anatomy. Clearly, I think understood for that. Another one for what's about the surgical or also the anatomical segmentations for the femoral head, concerning about the capsule, and this is the intercapsular part, and then the extracapsular part, which including the intertrochanteric area and the subtrochanteric area. That photo for the axial photo for the plain X-ray, and so difficult to manipulate as before. It's now easy, we can see this in the CT or the MRI, but this is it takes more complicated photo for the manipulation of the patient to get that axial one. for the head and neck and the trochanter's and to see the ischial tuberosity. We are now changing to another imaging modality. It's the MRI. The MRI, the magnetic resonance imaging, concerning about a magnet machine, a circle covering the patient, and then a table which can be transduced or passing the patient inside the tube. And that inside the tube, it's also a magnet and the radio frequency, what's called the machine, another one, and transmit that radio frequency machine or the impulses through this MRI coil. This is the coil which put or can be conducting between the whole magnet and the patient on the table through this coil. This coil which transmit the pulsations, which can be expected again from the patient and make the photo. Really, we can see that the MRI image is already only see the hydrogenated image. It's not a real. This is not a real image we can see. This is the hydrogenated atom image. We make image for the hydrogen ion which should be distributed all over the body of the patient, of an animal or a planet. That's the principal part for that one. If we change to why MRI? MRI is an excellent machine. Yes, it's an excellent complicated machine, but it's non-invasive. This is very, very important one. You can see the osseous part. You can see the chondral part, which means the cartilage, and the soft tissue. And you can see all of this. It's more aerial changes in the three components before than X-ray, before than the CT. It's so benefit for the joint effusion, means fluid, synovial covering, articular cartilage, subchondral bone, more, and things, the tendons and the muscles. We will see it later. When we have a hip joint complaint, pain, trauma, swelling, osteoarthritis, inflammation, the MRI, we now knows that it can be indicated when we have persistent symptoms or over with medical medication. This is the protocol for the, I think this is micromanagement for the photos, but we can make like a summation for that one. What's mean of T1 and T2? For simply speaking, T1 is called the time 1. So anyone can imagine this is time 1. T2, this is time 2. And also you know that time 1 and then time 2, so 2 is more bigger than 1. So it takes a long time, which is mean time 1, this is the shortest one, time 2 is the longest one. And from that sequences or from that times, you can create another soft tissue for the sequences, which is called the stair. You can hear it too much, the musculoskeletal imaging stair. What means for that stair? Stairs is mean the abbreviation for short T1, inversion recovery. So we know that the T1 is short, this is more short, and inversion recovery, we will invert the radio frequency, which we said before, الموجة بتاعت الراديو, in another way. What means that in positive or negative, below the level? No, it's in another axis. We have the 3 ways axis. So if we make T1 in one axis, so we will make the T1 short inversion recovery in another axis. Many photos for that, the axial, the coronal, which is can show the typical photo for the EP hip joint. And we can also see the sagittal, 1, T1 or T2. and very nice for the MRI or for the cross-sectional imaging modalities that you can compare with the two joints. You put the two joints in the same field for the imaging or for the scan. If we need for injection, we can do a contrast injection, so which can be through the interarticular like arthrogram or intravenous. What's the mean of the hip arthrogram or MR hip A, which means that we can introduce some contrast media interarticular to see some labral tears, to confirm the labral tears actually, to see the osteochondral lesion, and to see some of the loose spots. I think we can mix one contrast media for the MRI. The MRI contrast media is completely different in the chemical composite for the MRI machine than used in the CT or in the X-ray before. And its least amount should be diluted and should be have for renal function test exactly normal or at level nice, because it's a nephrotoxic for that one and can be relieved from our excreted from the patient, I think maybe less than more than 3 weeks. This is the T1. This is the T2, time 2. This is the gradient, which means in comparison or in between the T1 and T2, and this is the stair, which means that one, the short T1 inversion recovery. One of the characteristic photo, we are looking for the fluid. So the fluid means cyst, means effusion, the articular cartilage. So the T1 is short, it will be low. But the fat in T1, it will be high signal. It takes too much time to be returned, so it will be more bright. And the vice versa for the T2. The long time show the effusion more bright and show the subcutaneous fat, and the already the fat or air, it will be more low signal black. Okay. One of the demonstration for that one, you can see very nice the renal bladder here in T1, it will be black, and in T2 it will be bright. And also for the femoral head and the epiphyseal part for the fat marrow for the head, it will be bright in T1 because it had short T1 and black in T2. The MRI anatomy, very simple. This joint is ball and socket joint. The stapulum cover more than 40% of the femoral head. And there is a fibrocartilaginous labrum increased the thickness or the depth of the stapulum. And we know that more than 90% of the femoral neck, it will be intra-articular. This is more beneficial for that joint. Some of the axial views, and you can see very clearly the labrum. It's very nice. Triangular, low signal or signal loss for that one, because there is no cells or water in that. And this is the superior labrum. One of the ligamentous, it will be appear also fibrous tissue, so it will be black, all the sequences. So if we have any tear here, the fluid here, or the mini, it can be seen that maybe fluid effusion or an arthrography or by contrast. So it will very clear that if we have any bright signal inside the labrum, it will be suspected for labral tear. This is the usual photo. You can see here the very clear the acetabular fossa, the ligamentum teres, the transverse ligament, one of the synovial longitudinal fibers, very thin, it's very nice. And the labrum the superior one, the iliofemoral ligament, all of them is signal loss, is black. So any bright signal inside, which means suspected for tear or partial tear. I think that this talk, it will be more considered about the avascular necrosis, to more or less for the transient osteoporotic part for hip and the labral tears. I will be asked for Professor Gamal to give me another chance or another opportunity for 10 minutes or 15 minutes in every day for the hip joint, so I can put a micro details about the hip joint lesions to be more benefit for the attendance. So we can arrange it again, Professor Gamal. I think I bothering myself inside your, but it's an honor for me for this.
ده شرف لنا كبير يا فندم.
ده شرف لي انا والله يا دكتور جمال.
العفو يا فندم، شكرا يا فندم.
This is the significant. Why MRI? More than 100% for diagnosis in migratory osteoporosis, in bone marrow contusion and porosis, in patient with bursitis, in patient with stress fracture. It can only be diagnosed by MRI, reaching for 100%, 90% or over 90% about the avascular necrosis. That's why we said that why MRI in hip joint lesions. We will start toward the avascular necrosis, and we can see the causes or the etiology about a septic leg. So you can see the enumeration for the whole causes, starting from alcohol, pancreatitis, trauma, calf-Percy disease, esophageal dysplasia, kosher disease, more than one item for the etiology. Looking for the avascular necrosis, it's very nice photo for that, which is called the double line sign. We always think that it's the anterolateral aspect, but no area can be protected. All the socket, all the femoral can affect for the avascular necrosis. The MRI more sensitive, more specific. And this is, we can explain the double line sign. We have fluid sensitive sequence like the stair, or some sequences called the water sequences to see the more water component inside the bone or the osseous or in the cartilaginous part. Low signal, we have low signal, and then next to high signal, hypervascular line. This is the extent of the lesion. So the extent of the lesion, when in a progression, it will be go down, big, big, big. We will see it in another one. In the federal one, the FICATE classification about the Federal Committee for the Orthopaedic Imaging, starting from the pre-radiographic, which means can be positive for the MRI by the edema, and also the pre-collapse, the second one, we have mixed sclerosis, subchondral cyst can be seen in digital radiography or in CT. We still have an edema, and then for the crescent sign, and then our cortical, starting cortical collapse, we now have bone necrosis, and then the advanced one. The man who gave us for that FICATE classification, you can see that the man here is like laughing, and then worry, and then it can be angry. You will let me now, you will let me see like this, you will be neglected, you have to start with management. That's why he is looking anxious like that. What about the MRI for that appearance? The gold or the what you are looking for, the marrow edema, the marrow water, which is more sensitive in the MRI, in T1, stair, I think more than fat saturated sequences, starting with edema, and then starting with edema with line. You can see it is very clear. The line is complete or a circle or half diagonal. And then the fluid signal now more. So it would be low and high, and the heterogeneous part of that area is like a heterogeneous bright and black signal in T1 and T2 and stair and the gradient. And then we have cortical irregularities and affection of the acetabular roof with that. This is another classification. It's called ARCO, the Association Research Osseous Committee. For the most recent, this is done classification last year, and they are putting the stages over there, and then the finding, and then he combined with the scintigraphy, the bone scanning, and the CT and X-ray and MRI for make more quantitative evaluation about the affected area of the femoral head. So the area can be done for that, and the software of the MRI can give you that one. It's 50%, it's 35% affection like this. So you can manipulate with the patient according to the affected percent of the femoral head. Another items or another merit for the MRI is the modified Kerr-Paul methods, which I think you can imagine we can combine or combine the images and or combine the quantitative affected part through the sagittal view and also the coronal view. If we make that angle and this one for the affected part from the femoral head and combined with them, if it is less than 200, so maybe a low risk. More than 200, it will be moderate risk. More than 240, it's more and high risk. And this is another modified Kerr-Paul method for that one. This is another examples and photos for the avascular necrosis. It is the plain X-rays. You can see some changes about the femoral head, but I think the left one is more affected than the right, and it can be so obvious. In T1, the urinary bladder is black, T1 is still, and this is T2 and gradient, and that one is the stair, which our called the gradient. Some machines is called it like that. The urinary bladder is already bright, and you can see the affected area of the femoral head, but more on the left side, subchondral affection, fluid go inside the bone like that. It's more osseous defect. So it's more affected on the left side than the right side. What about the diffusion? I think the diffusion, it takes more than one lecture for that to explain. This is magnificent created soft tissue from the principal part of the MRI. It's looking for the body's movement. It's not the water content itself. No, the molecules movement. I think this is very important sequence. So you cannot need for contrast media. And he has also quantitative and qualitative methods is called the ADC. The ADC ratio, it gives you a numbers. So you can have a limited numbers, or they can call it a cutoff numbers. So if we have more than 1.6, this is bad prognosis for that. The ADC ratio for that. The machine, it will give you that ratio. If it's already more than 1.63, this is the cutoff. It will be more bad prognosis for that joint management, suffering from avascular necrosis. The alternative one for that is the transient osteoporotic hip. This is bone marrow edema syndrome. This is very nice. This is reversible, not like that one for the avascular necrosis. painful, and you can see that extensive area of bone marrow edema, water inside the bone, more than one. You can see it very clear. And there is some crescent area here starting. But we can use here the intravenous contrast. So it's resolved spontaneous, about maybe from over 6 months, and parts from the skeleton. Yeah, it's not only the hip, it can be migratory. So it's called regional migratory osteoporosis. The one can see it's a bone marrow, and he can enhance. So there is no obstruction for the visits, no obstruction for ischemic part. No, the contrast can go to the femoral head and neck directly. It's only a bone marrow edema. We can see some varieties for that. You can see the stair. At the stair one, it's completely bright. Very nice photo, like the urinary bladder. So it's more obvious. You can see it multiplanar, axial, photos, coronal, sagittal, more than one in one sitting place. But if you do this in the plain X-ray like before, it takes a much films and much exposure to the ionizing radiation. There is another item which is called subchondral occult fracture. I think maybe it comes in the extremities, in the elderly and in the youngest one, and leads to extensive marrow edema. And you can suspect it from that the patient has minor trauma, and then after a few weeks, the pain is progressive, and then you do CT, not too much equivocal, and then you do MRI, it's completely bright. So this is a stress fracture. This fracture diagnosed marrow edema, low signal fracture line on T1 or T2, like that one. So we can reach for algorithm to solve a problem for the 3 items see before. We have bone marrow edema. So the bone marrow edema, it can happen in avascular necrosis, in transient osteoporotic hip, or stress fracture. What we will do? All this marrow edema, T1 low, T2 high, stair, it will be more bright. When associated with more edema-like pattern, so the transient osteoporotic hip will be suspected. If we have any band of low signal intensity inside this edematous area, we will see the shape of this low signal intensity band. If it is convex, so it will be subchondral stress fracture. If it's concave, it will be more suspected, circumscribing all the necrotic segments, so it will be for the avascular necrosis. More this than if we give gadolinium intravenous and cannot enhance, so it is avascular necrosis. If it is enhanced, it will be stress fracture or transient migratory osteoporosis. We have this diagram. That one triangle, the avascular necrosis, can come, or the transient osteoporotic or the subchondral fracture can progress to avascular necrosis, and this is proved. And the subchondral fracture or the transient osteoporosis can be manifest like this. So take care. All the 3 items, you should differentiate from them. All of them have bone marrow edema. All of them have this pain, that the same clinical manifestations. But we have certain items. If we have any crescent line obscuring some of the edematous area, so we are looking for that. Is it concave or convex? And then we can give intravenous contrast to solve this problem. I don't know if I am too much time for me for that. but take care that from that
لا يا
table.
فندم take your time، احنا معانا التايم
انا
تمام.
اسف، انا اسف يعني،
لا يا فندم
معلش،
احنا
I'm
معانا
sorry.
التايم تماما، احنا مستمتعين يا فندم. take your
الله
time يا
يخليك،
باشا،
الله يخليك يا فندم.
احنا مستمتعين يا فندم.
التيبل ده بس هو this table is very important for that because the avascular necrosis destroyed is the causative one and is the treatable one, and this is a curative one for the transient osteoporotic hip. That's why we have to conclude, we have to confirm. Some of the clinicians take the line we can do bone scan. I know that bone scan have more sensitive and specificity for differentiation, but it's ionizing radiation. You cannot do this for the pregnant. You cannot do this more for the children or the young people. So when avascular necrosis and the transient osteoporotic hip is equivocal, do bone scan. I think it would be more beneficial if there is equivocal signs or features. I think maybe we can go to the another one, the femoroacetabular impingement. Professor Gouda, Muhammad Gouda Muntasir, I asked him, I think he helped me too much today, and he will describe for me some of this impingement, how it can be manipulated for us. And he already also described for me the cam type and the pincer type. By the way, I look for that cam, what does it mean, what is this abbreviation? I look so much, this is abbreviation or a name for a person or like this. I didn't reach for that. But this is dysmorphic bulge overgrowth for the anterolateral femoral head junction, and the pincer type is coming to the acetabular part if we have mixed type, so it will be cam and pincer type for that femoroacetabular impingement. I think maybe we can have photo. The three-dimensional, I think maybe more, but the most accurate diagnosis is through the MR arthrography. We, by the way, we are looking for the alpha angle, which is a more frequently cited parameters to confirm the cam lesion. This is very nice photo. If we have a line in the axial plane, central for the femoral head, and the other line for the end of the covering for that one. This is called the alpha angle. I think it will be, if it's more than 55, it's indicated for cam type impingement for the femoroacetabular impingement for that one. Another items for the cam deformity, and this is for the pincer one, the B protrusion already for that one. I think C, it's a cam deformity again. And D, it's some synovial herniation for the small subchondral defect in that one. The labral tear. The labral tear, we can do some sequences to see the water content for the joint, but if we don't have too much joint effusion or like that, they can do it artificial through the arthrography. And I think the clinical, it would be a painful clinic, clicking or transit looking, and the pain reliever, it can be done through the injection interarticular, but we already approved that the MR arthrography have more than 90% for sensitivity and specific for 100% to detect the labral tear. If we see a cyst, it means that there is underlying tear because the cyst will obscure part of from the tear. If you reassess, so it's already underlying tear. This is completely approved. Another one, the prelibral recess, if you obscured or it's lost, so this is abnormal labrum, so it would be indicate tear. The intrasubstance inside the labrum, like the menisci in the hip joint, it's called degeneration. The osteoarthritic changes, I think the main item for that, it would be the narrowing of the space, and this can be easily seen through the MRI. We have also some features like migration of the supralateral femoral bone, lipping, osteophyte lipping, sclerosis, pseudocystic changes, subchondral pseudocystic effusion, and the vacuum phenomena, to put that one. I think maybe you can see it like that. All that manifestations can be seen: subchondral cysts, already abnormal marrow signals, the irregularities and the ill definition of the joint itself. You cannot see the cartilage, you cannot see the acetabulum. It's ill defined. The whole joint space, it's already obscured for that. For destructive osteoarthritic changes, it would be more than the articular surface for the femoral and also the acetabulum. It can be progressed to bone resorption, and also the loose bodies, which more benefit for the MRI arthrography, and can be diagnosed a list of etiology, like the pigmented verinoidal synovitis, the traumatic part, the synovial chondromatosis. I hope that I can make like a small review for the hip joint, and as I see that maybe I can arrange with Professor Gamal in another sessions. It could be less than 15 minutes or 10 minutes to make like a micro details for each joint, for each disease. It will be more benefit for the candid, and also for me to review my my picture for that one. I would like to thank Dr. Ahmed Hilal, Dr. Mohammed Shapouri, Dr. Meha, who helped me for that arrangement of that, our preparing my talk. And many thanks for Dr. Gamal, and also the committee for the orthopedic surgeon. At the top of them, Dr. Jalal Kazim. It's our eminent professor for that. All of us, I think, know that magnificent person for working for our hospital for that. Thank you, Dr. Gamal, and thank you for Dr. Saad. I hope that I can give you a simple review for that one. شكرا يبي أو متشكر جدا.
Thank you so much, our beloved professor, Professor Medhat Refaat, professor and head of Diagnostic Radiology Department in Benha University, and Vice Dean for the Postgraduate and Research Affairs. شكرا جزيلا أستاذنا الفاضل أستاذ دكتور مدحت بيه for this marvelous talk. حضرتك بصراحة يعني وضحت لنا تماما what's meant by MRI of the head. في عملت حضرتك outlining لكل الديزيزز of the head اللي بنشوف فيها MRI، وما بنبقاش عندنا background عن how to see and how to demonstrate and how to make a comment on the MRI. Thank you so much, sir. وتشرفنا بوجود حضرتك النهارده دكتور مدحت بيه.
ميرسي قوي يا فندم، متشكر جدا.
شكرا استاذنا الفاضل، متشكرين استاذنا الفاضل.
Great appreciation. Thank you very much. تفضل.
شكرا يا دكتور مدحت.
شكرا يا دكتور سعد، الله يخليك.
هناخد questions للدكتور مدحت بيه.
اتفضل.
Any questions؟ دكتور سعد في questions قدامك؟ انا هو في just one comment ان المحاضره رائعه يا دكتور مدحت بيه.
لا هو كله بيثني على المحاضره بيه والله.
انا شاكر فضلكم يا بيه والله، يعني it's a great opportunity for me. يعني انا الحقيقه كنت متوتر جدا لان اول مره ابقى حاضر خارج الاشعه، يعني الحقيقه الدكتور جوده اشور مي ويعني ارجو ان انا اكون قدمت اي يعني ولو حتى
محاضرة رائعة يا فندم. It's a marvelous talk يا فندم.
شكر جدا يا ميرسي، ميرسي جدا يا ميرسي جدا، شكر جدا.
شكرا دكتور مدحت.
اتفضل يا فندم، اتفضل اتفضل.
مع السلامة.
انا هستاذن سعادتك يا فندم تستوب شير.
اتفضل. حاضر.
هنستوب شير.
حاضر كده. اوكي.
Thank you so much. شكرا جزيلا استاذنا الفاضل.
اتفضل.